Right, people, so happy quarantine life right now. Hope everybody's okay out there. Um, so just to give you guys a little bit of an update, I've had a lot of mixed emotions this past week. But I had 5 patients on a virtual call, which I'm very thankful for. So much different than seeing patients in person. And the calls went well. In fact, I had a patient reach out to me yesterday, and he just totally made my day. He's like, I have muscles in between my shoulder blades that I didn't know I had for 20 years. And I'm like, okay, this is good. Starting to learn how to slow things down, because in the CrossFit world, everything seems to be fast-paced. So now's definitely one of the perfect times to really hone in on your movement patterns and focus on your quality rather than your quantity. But other than that, just kind of still keeping my same pattern with physical therapy, as well as my training pattern too. So hey Maria, Kelly, yeah. That's just kind of a little quick update. Every day I kind of just keep my consistent pattern. I get up at 5 every day, try to be in bed by like 9:30, and then try to hone in on my little aches and pains, because believe it or not, yes, time is a little bit more abundant right now. So personally, I did overtrain a little too much last week, so I had to dial it back. Lots of mid-back pain and discomfort. So I just kind of took a chill pill this week and had my mom put the cups on my back. So I do have little tattoos from that. Anywho, so that was a quick update. But tonight we are talking about Achilles tendonitis. So if some of you joined last month, we talked about plantar fasciitis. Kind of the same deal, right? Because it's not necessarily a degeneration of the tissue of the tendon behind your ankle that connects to your calf muscle. So you can see that on the previous Fortress page on information and visualization of where the Achilles tendon is down by the foot. So not necessarily degeneration, but the research shows that we don't know. Unfortunately, we don't know why Achilles tendonitis or Achilles tendinopathy develops. However, there is a correlation with a change in too much external load, too much compression into that tendon, repeated over and over, and even tenfold, where how I explained, according to the plantar fasciitis video, that if you have a marathon runner and they're training for a marathon, and then they suddenly increase their mileage to like 100 miles a week, going from 50 miles a week to 100, that's a pretty significant change in volume and load on that tendon. So then that tendon doesn't know what to do. So therefore it starts, signaling pain signals, telling your body like, okay, something's going on here. So as far as Achilles tendonitis goes, yes, there's probably about 3 to 4 things that we look for when someone comes in for physical therapy. And number one is usually a patient is going to have pain with palpation or pain with touching the tendon at times, especially in the morning, right? Because when you're sleeping, you're all, relaxed in the bed, and then you get up and you first put your feet down and you take your steps in the morning, and you kind of feel that difficulty and stretch on the back of that calf, which may travel up to the back of your knee, because that's where the calf muscle connects. The calf muscle connects in the back of the knee, and then it turns into the Achilles tendon and attaches to the bottom of your heel. So morning stiffness, especially, pain that is very prominent, like as a patient, you can point with one finger where the pain is on the tendon. Typically, it's in usually the mid portion of the tendon, or it might be down a little bit more towards the heel where the tendon actually connects to the bottom of our foot. Additionally, I took some notes here. So the other thing that we look for too is the reproduction of your pain with the correlated activity that you're doing. So if running a certain amount of distance, for example, it might be 3 miles, and you start to feel that Achilles tendon pain at the 3-mile mark, that's definitely telling your body something to be like, okay, this tissue cannot tolerate more than 3 miles, and if you continue going, some bad things might happen down the road. So the tendon's tolerance to capacity and load and compression. So jumping, sprinting, hill running, stair running, those are plyometric type movements. So, think of people who do track and field, high jump, long jump. That tendon in the back of our calf that connects to our heel has to store elastic energy. So that tendon at some point has to be stiff, and it also has to become elastic. So it has to be able to elongate like a rubber band. But if it elongates too much, or you get too much compression, i.e., a runner who's training for a marathon who is running 50 miles one week and then the next week they bump it up to 100, tendons don't like that. And tendons are very sensitive to load. So that's kind of like the 3 to 4 main reasons that we look for when a patient comes in for physical therapy for an evaluation. Now, sometimes someone might have some redness or maybe some swelling on the back of the heel. I did post a previous post a couple weeks ago regarding that. That is known as a pump bump. So I don't know who named it. Someone in the medical field probably named it a pump bump. Who knows? But with our tendons, and this goes for any tendon in our body, it has to have fluid around that tendon, and that fluid can kind of get stuck and create like a little swelling pocket. So it's just a little swelling pocket that can develop on the back of the heel. In addition, irritation can continue, not only the swelling's there, right, taking up space where it shouldn't be, but also the patient on the type of shoe wear that the patient wears. So that can cause irritation to the outside of the skin too. So we definitely look in the type of shoe wear the patient is wearing. Additionally, some other aspects of Achilles tendonitis, it tends to get stuck in this kind of inflammatory type issue. We still don't know how it kind of maybe causes a degeneration of the tissue or decreasing. It definitely decreases the tissue's capacity to accept external load because tendons are very sensitive to change. Another thing that I would vouch for in order to lessen the tension or compression load through the Achilles tendon is the use of a heel lift. I did post a video this morning regarding myself demoing how to appropriately put that heel lift in your shoe. Now, there's different heights of heel lift. Usually, I just recommend a heel lift that might be about a 1/2 inch thick to begin with. And you can get something like that off Amazon for like $15. It comes in like 3 or 4 different layers, and you can peel back another layer to create a smaller and smaller heel lift. So the point of that heel lift is to take strain off of that Achilles tendon, right? Because when we stretch our ankle, just like you mentioned, Maria, a wooden slant board, when we stretch that tendon, you're causing some discomfort into that tendon, especially if there's pain. So when you're walking and going up and down curbs and you're squatting and you're stooping and you're performing your normal daily routine, that tendon gets this low grade stretch consistently over the day. So it doesn't like that, right? Because it's sensitive to compression and loading capacity. So by just adding a little bit of a heel lift, and what I demoed in the video was 8 millimeters, very, very small, just lifting that heel up with the use of that heel lift will take that just a little bit amount of pressure and compression off of that tendon. So you rest that tendon. Now, speaking of rest, when we get hurt, we tend to rest, right? Some people's thoughts of rest is sitting on the couch all day and not really doing anything, right? Or the way that I'm trying to hopefully educate my patients and others through this type of venue as well is we want to promote more of an active rest recovery type deal. So with a bout of Achilles tendonitis, you might have to switch up your load, number one, right? So probably avoid running for a little while, because running is typically an aggravating issue. And any other activity that might be your issue of concern. So maybe jump roping, or maybe you are a track athlete. So we just might have to put running and sprinting and long distance running and any jumping type loading motions off to the side, at least initially, until you can kind of get this pain level to kind of come down. And then while that activity level that you put off to the side is kind of out of the picture just for a little bit, we can add in that heel lift just to take that tension off the Achilles, as well as switch up your routine, right? So instead of running and jumping, right, which we should kind of just put that off to the side, which is typically an aggravating factor with Achilles tendinopathies, you might try like biking, right? Whether it's like on a road bike or even a stationary bike. Obviously at the CrossFit gym, the assault bikes or the echo bikes. Even the rower might be a little iffy. It just depends, because your heel goes in that slot in order to connect your feet to the rower. And then even the Concept 2 bike ergs. So you're not body weight compressing that load, right? And this is definitely during the early phases. And then in turn, right, you're still getting cardiovascular fitness. So you can still do, intervals and all that fun stuff. After going through bouts of training leading up to my Miami competition 2 months ago, swimming, oh my gosh, I cannot tell you how much I would and now can truly vouch that swimming is probably one of the most best alternative cardiovascular endurance exercise, as well as clearly you're not loading compression through your joints. The buoyancy and the compression through the water is helping things heal. So I definitely advocate to patients to try to see if they can have access to a pool and just swim and move. And I am not a professional swimmer or anything. I had to learn a lot the past 6 months on how to swim and breathe. So that's definitely something that we like to look for early on in the treatment process. And there are other things that me personally that I like to do, because I know research backs it up and I've been trained on it, is dry needling. So I will load that tissue up as much as the patient can tolerate. I won't put a lot of the sterile needles into the tendon. So I kind of just build every time that patient comes in. Because my goal for the dry needling is to stimulate a better inflammatory process, right, to kind of jumpstart things. Just like how you jumpstart a kind of dead battery in your car, right? You got to get the juices flowing again in order for things to start to smoothly come back together. And then we also add some kind of what we call isometric exercises. So you might be on the edge of your step on the ball of your foot, and then you kind of flex up onto your toes and hold that position maybe for 10 to 20 seconds, and then you kind of bring your heel parallel with your step as well. Hold that for 20 to 40 seconds, and then getting that heel below that portion of the step. So isometrics. So you gradually add this eccentric controlling, but with points of isometric holding at different various degrees of that portion of the tendon. So don't worry, a video will be coming out next week on that. So those are some early phase type things that we try to focus on. Clearly, we got to control the pain. We got to get it under a better management level for the patient, and to also for them to continue to exercise the other parts of their body, right? Arms and the other leg, because typically with Achilles tendonitis, you're not really going to have both Achilles inflamed at the same time. I've never seen that. I'm sure there's probably some cases out there, but I've never experienced or worked with any patients of that nature. Plus, if it's happening on both feet, I would not think Achilles tendonitis. I would have to probably roll out the lumbar spine first. So, throughout this whole process of rehab, we always want to continue to monitor, especially the 24-hour response from the patient. So what did we do on that day of therapy that you came in, and then how did you respond 24 hours later? That tells me that, okay, if the patient's pain didn't super exceed, a 6 or 7 out of 10, 10 meaning emergency room pain, but and 0 meaning no pain. So if they were able to tolerate and voice what their pain level was, but it wasn't really significant in my mind, and then us correlating back and forth, then I know that dosage that we did before was pretty appropriate. So, the next bout of physical therapy, we kind of add a little bit more and more active therapy exercises. So we get to like the strengthening portion up the chain. So some quad, some hip, definitely a huge proponent of the hip and booty, core, isometrics, planks, single leg work, trying to be more stationary with that foot. So if your right foot is affected, I would keep my right foot planted on the ground and do a reverse lunge or a forward lunge. And then you can even load it, right? You can even hold a kettlebell or dumbbell and then do a forward or backward lunge. So we want to focus up the chain. So strengthening the quad and the hamstring muscles around the knee, as well as the hip musculature and core. And then this still correlates and corresponds with the patient continuing to be on the air assault bike or some type of non-weight bearing cardiovascular piece of equipment. So running is still a little bit off to the side. So again, you might vouch for rowing, biking, air assault bike, or even a concept 2 bike, or even the ski erg, because your feet are planted and you're just hinging at the hips. So that's definitely a gradual process of strengthening that whole kinetic chain, meaning the leg. That's what I mean by kinetic chain, to hit each major joint. And then going into what the research terms as a stage 3 is starting to add that compression back in, right? So testing out, maybe you're going to do incorporate 100-meter runs back into your workouts a little bit. See how you feel. Again, and taking in consideration of that 24-hour dose response. So you as the patient have to be mindful on how much intensity you put out that day. How did you respond immediately after, during, and later on that evening. And then, of course, 12 to 20, especially that 24-hour mark later. How does that Achilles tendon feel? So, as a physical therapist, yes, I do a lot of manual physical therapy, and then I usually send my patients home with 2 or 3 exercises, and then a lot of education on how to incorporate that. Maria did mention some stretching of the Achilles. Yes, I do advocate for that, but I think that's once the pain level kind of subsides to a better tolerable level, and then just gradually knowing your tolerance as the patient, how much stretch to put in there. But I'm more focused on actually the strengthening of the whole leg and tolerance, right? Because these tendons are very specific to load. This is definitely where, and Maria, you could probably vouch for this, where tempo training work comes in, because I can give you a therapy band and I can tell you a specific contract out 3 seconds, hold for 3 seconds, contract back in 3 seconds, hold for 3 seconds, right? So that is a way to really strengthen the tendons in our body, because every muscle has a tendon. That's how it connects to a bone. So incorporating this through your training regimen, as well as into your rehab exercises, is tenfold. It is money. And then the last phase, obviously getting into being a little bit more specific, right? So gradually sprinkling in, okay, can this person, yes, for sure. Can this person tolerate a 400-meter run repeatedly within a 30-minute period? And then you might sprinkle in maybe some kettlebell swings and like a elbow plank hold. Right? So you gradually throw one piece of work that was kind of set off to the side. So running, we'll just use running as the example, and you give that patient a realistic goal to hit. Can they hit a 400 without pain? Checking that 24-hour dose response. Yeah, I'm cool. Okay, so let's load that again, but maybe we'll do a couple more reps. So it's always going to be based on symptom response, that 24-hour or even 48-hour mark. So I want to get back to this heel lift very quickly. Should you exercise with a heel lift or not? I think, especially in the early phases of Achilles tendonitis, or when the patient sees me, which that typically isn't the early phase. It's like down the road trying to get them, melted after being the snowman or whatever, the snowball. I talk about the snowball all the time. So they just came to me with this big snowball, and then we have to make this snowball smaller. So the rehab process will take a long time for that. There's a patient in particular I've been working with for over a year, and he's just now feeling pretty good. But he came to me a little bit late in the game. But he was in it to win it. So going back to that heel lift, yes, I think exercising with that heel lift, in fact, don't just put it in one shoe. Order 2 heel lifts and put it in both, because if not, you're going to feel weird. You're going to feel off when you're trying to do an air squat, or even just walking around in your normal daily routine. Putting the heel lift in the other good foot, it's not going to hurt you. So create balance at your hips rather than being like, it's like you're stepping off a little ledge every time you take a step. So yeah, I would definitely promote the use of a heel lift when we start getting back into more exercise. And being more aware of your dose response after, right? Your 24-hour response to exercise. And then gradually, for example, we'll just use a 7-day week span. So on day 1, you might exercise with that 1 hour bout with the heel lift. The next day, you might exercise 30 minutes with that heel lift. Halfway through, take that heel lift out and then see how you do. Then you might repeat that same thing again, pending your 24-hour dose response. And then perhaps day 4, you might try 45 minutes without that heel lift, 15 minutes before. So you might just utilize that heel lift in your warm-up and then take it out for the rest of that workout or training routine or physical therapy routine, and then check your response, right? And then it's just this gradual taper of the use of that heel lift. I don't see any bad thing about that. Now, some patients will come in with a walking boot. Is that necessary? 9 times out of 10, I don't think it is. It just causes what we call disuse atrophy. So it's just going to kind of promote the calf muscle to get smaller because you're not really using it. You're not using the other muscles because you're in a rigid boot. And then you're going to probably get some discomfort or some pain signals into your knee and then your hip and your low back. So I don't think a walking boot is absolutely necessary for someone with tendinopathy. Now, if they had surgery, yes, like that's definitely vouched for. Achilles tendonitis, from a physical therapy standpoint, it can be very difficult to work with. Especially if the patient is not on board at the beginning when they come see you for the initial eval. Education is huge, and that patient has to be able to change their behavior. If they don't put aside or just put in the closet a little bit whatever activity that seems to be aggravating them, it's just like leading a horse to water, but you can't force it to drink. That patient has to be in it to win it with you. And, if that patient doesn't really see eye to eye with me that day, then, I'm not going to give up on that patient, but I might try to explain it a little bit different to them. I'm all about foreseeing in the future. So this is something, going to physical therapy for something like this will set you up for success in the future. If not, it's going to set you up for failure later on, because if you keep doing the things that you're doing, that tissue or that tendon, it's not going to like you, and soon it's going to break down. So, and that's where you go see your surgeon, and we don't want that. So physical therapy can definitely be very effective, but the patient has to be in it. So patient education is key, and then the patient understanding that process, that the healing is going to take a little while. I am a firm believer of incorporating dry needling and even body tempering onto that tendon. Even though we still don't know a lot about body tempering, but I can vouch for it as well. Like just having that compression around the tissue, or the calf muscle, and even the knee joint and hip joint and ankle joints, is twofold. Like it just makes you feel better. And yes, for sure, Maria, consistency is key. Consistency with everything that we do. Consistency with what we're doing right now with stay-at-home orders, from the pandemic that's going on. So, yes, you're going to have ups and downs, but the ups and downs will hopefully be more leveled off, right? Or even we want more ups because we always think up is good, right? We want more good days than bad days. Achilles tendonitis is definitely tricky to work with, but there's a lot of things that physical therapy can do, and it may take a long time, but I think a patient will learn a lot throughout the process, that 2 minds is better than 1. So that's kind of a little bit of tidbit on Achilles tendonitis 101. Unfortunately, the research, we don't know what the hell it is, so we don't even know how we get it. But we do know that tendons respond to load, and they're very sensitive to that. So if you abruptly add something to your training routine or your daily activity routine consistently over time, or within a short period, and you're like, my Achilles hurts, that's probably telling you something. Just like what I did last week. I have all this time on my hand, kind of. I'm like, oh, I'm just going to go exercise 3 times a day. Yeah, my body's definitely paying for it. So I dialed it back for sure this week and just kind of did me. I did a lot of banded work and incorporating some time under tension with whatever portion of the body may be, even the with the ankle, is twofold, because you're getting isometrics, you're getting the concentric work, and then you're getting the eccentric work, and then filling around the circle, stability, balance, endurance, strength, and then you add your cardiovascular portion, riding that bike, you're getting that blood flow pumping into your heart, right? You're exercising your heart. So, so for sure. So 30 minutes is up. Hopefully everybody's doing okay out there, and if anybody watches this video, I will be uploading this to YouTube. We'll see what next month brings. I'm going to try a little something perhaps different. I'll keep everybody posted. But for now, thank you for watching, and I appreciate everything. And again, if you guys have any questions, definitely send me a DM. If you're in the Charlotte, North Carolina area, or even the state of North Carolina, state of South Carolina, we are doing virtual physical therapy. You know, and this is going to be in a service that we're just going to continue even when Fortress returns to in-person visits. Yes, we were thinking about that later on down the road, but I think it's here to stay, because you know, change is good. So anywho, if you guys have any other questions regarding Achilles tendonitis, please reach out. You can reach out to my Fortress Physical Therapy Facebook page. I am on Twitter at Dr. Amy Bullock PT, and then as well as obviously the Instagram page too. So thank you guys for watching, and I'll talk to you guys later next month.